Okay, well, considering we have doubled the attendees in the past minute, I'm going to go ahead and kick things off. Good morning, everybody. Welcome. I'm Mary Patterson. I'm the Vice President of Clinical Operations and Regulatory here at BrainCheck, and I'm going to be the host for today's session. Again, thank you so much for carving out time this morning for what we truly believe is going to be a meaningful conversation um, around digital health and the science of early detection. That's going to be the focus of today. Some of the content will be focused on digital assessments, blood biomarkers, and anti-amyloid therapy, and what it means for your patients right now. Before we dive in, just a couple of housekeeping things. As always, we are going to be recording this session, and then a link is going to be circulated to all attendees, as well as the slides for reference after this session. Importantly, we want this to be an interactive session and valuable for you. So we're going to absolutely be doing a Q&A today. So you can submit questions throughout the conversation and throughout the slideshow. At the bottom of the webinar screen, you should see a Q&A option available at the bottom panel. And so please submit questions throughout the webinar. We'll be able to address some of them if they're relevant to the conversation at hand as they come up, but we have dedicated time at the end of the session also to address any remaining questions and really open up the conversation to all attendees and broaden the dialogue around this important topic. I'd like to introduce our esteemed moderator and speakers for today's conversation. Moderating the discussion is going to be Phyllis Ferrell. So Phyllis, who many of you likely know, is an innovator, investor, and incubator for brain health and longevity. She spent 3 decades as a life sciences executive at Eli Lilly and Company, and post-retirement from the pharmaceutical business, she now works as an independent advisor for multiple nonprofit and private sector clients, managing director of the Clinical Trial Recruitment Laboratory, the USC Schaefer Policy Institute, among many other things. I think that there's not very many things that Phyllis doesn't have her hands in the Alzheimer's space and patient advocacy side of Alzheimer's technology and drug development. So additionally, she is on the board and oversees the Alzheimer's Drug Discovery Foundation and is a contributor on brain health for the Forbes Business Council and is the Chief Impact Officer for the Startup Health Alzheimer's Moonshot. So quite a long list, Phyllis, and we're incredibly happy to have you here moderating the discussion and just continuing the conversation around early detection and how we can all contribute. And then our featured speaker today is going to be Dr. Stephen Bekanich. He's the Chief Medical Officer here at BrainCheck. And Dr. Bekanich is a palliative medicine physician, healthcare executive with deep experience in value-based care and care delivery innovation. He's the co-founder of Iris Healthcare and disease-specific advanced care planning company that was acquired by Adelaide. And was really influential and one of the founding creators of delivering a really critical need for patients and is applying that skill set now here at BrainCheck to further our program. And so with that, I'm going to hand things over to Phyllis to take us from here. So Phyllis, the floor is yours. Thank you to
Mary.
Everyone for being here.
Thank you so much for having me, and I'm excited to have this conversation with Stephen. Stephen and I could probably fill the whole time just in a chat with each other because this is a topic that we're both very passionate about. But as Mary mentioned, this is going to be a lot more fun if you all join in with your questions. There is a question spot for you to enter in anything you want to ask. Feel free to go ahead and fire those away as they come up. If I can grab hold of them while we're in the moment, I will. Otherwise, we'll try to make sure there's lots of time at the end for Q&A. So a quick overview of what we're going to do today. We want to really dive in on 3 main aspects of creating a true brain health service line. And that starts with the early detection of cognitive impairment and specifically what is available for us around digital assessments and why they are or aren't getting used. Then we're going to move into accurate diagnosis. And we want to talk specifically about the advent of blood biomarkers and how these have really transformed the ability for us to understand what is the pathology that's underlying some of those symptoms. The third thing we're going to talk about is some of the new innovative therapies. So, after 35 years without a new therapy for Alzheimer's disease, we now have anti-amyloid therapies. And you're probably having questions coming at you. What are they? What kinds of things do you need to know as you think about these new therapies? And then tying it all together for specifically in a primary care office, how do I put these three pieces together? And I'm thrilled because Stephen Bekanich, who is the chief medical officer on with me today, is an expert and can help walk us through some of these questions. So, Stephen, if you're good, I'm going to go ahead and jump in with our first topic.
Let's go.
All right. Okay, so we're going to talk about digital cognitive assessments. A recent GSA report, that's the Gerontological Society of America, says 95% of patients and primary care physicians want to know what's going on with their cognitive health. And yet it's really not had the type of uptake that we'd like to see. So we know that PCPs want to use these digital cognitive assessments, yet most still rely on paper-based tools if anything's happening at all. Primary care physicians talk about electronic medical record problems, unclear reimbursement. How do I get my time reimbursed? Obviously, challenges with the annual wellness visit, training, workflow. And yet, there's really good data around how using these digital cognitive assessments can be helpful, both to patients, but also within a health system workflow. So, Stephen, what do you see in your day-to-day experiences on the barriers and the enablers and why we should be really working towards making more use of cognitive assessments in general and specifically digital tools?
Yeah. So I'm a practicing physician. I see patients in their homes, in clinic, and in the hospital. Take care of lots of folks with dementia at all the different stages. Right now, dementia is severely underdiagnosed. It's about 20%. So if you look at mild cognitive impairment and the different stages of dementia, about 20% of our senior population fits into one of those categories or has the diagnosis. But about 70% of them are undiagnosed. So there's a giant gap there. And then I think that perhaps even more importantly, the care or the plan for the care after the diagnosis is made. Most caregivers, people that are taking care of the patient, which is usually either a spouse or an adult child, they don't have any idea what to do or how to best serve that patient with the diagnosis. Those numbers, the gap there in terms of what people need versus what we deliver to them is even greater than 70%. It's probably close to 100%. They just don't get training. They don't know what to expect. And so the first step in all of this is making a diagnosis. And right now, we can screen people, and then if they screen positive, we can do an assessment, which is more in depth. And I will tell you, in my own clinic, we're still on paper with this. So, it's a giant issue. There's not any type of integration into my EHR. I will often dictate the results of the assessment. We don't have, most docs don't know that if you do a digital assessment, you can get reimbursed for that. And so, we tend to not do things that we don't get reimbursed for. And then there's always staffing issues. Everybody's stressed, nobody has time. And so traditional slums or MoCA, mini mental status exam, very hard to administer, very hard to document. And most people don't get compensated for the work that they put in. And so that all leads to that giant gap in diagnosis that I'm talking about. A digital assessment is much more reliable. So for a number of reasons. So it adjusts, for instance, for education level. It can change based on culture and education. You can use different tests. There is not any bias from whoever's administrating the test. The tests are timed. Digital screeners and assessments are just far superior to the way that we've done these things, and they can be brought into the EMR, and then practices can bill for these. So I think that's really important to understand is that you can be compensated for the time that you put in. But really, what we want to do with these digital cognitive assessments is make sure that patients get the diagnosis. Things for everything that we have available for dementia care, whether that's new drug therapy, caregiver support, its impact on the patient's other medical problems, right? Like maybe they have chronic kidney disease and they're inching toward dialysis. All of those things, they first rely on having a diagnosis. And so if we're not doing this, then we're really not serving the patient and the caregiver the way that we should. We need to work on closing that gap, and the digital tools can help us do that.
Thank you so much. I think it's amazing to hear that you're not even able to get the digital cognitive assessment in your own practice. I think we hear these barriers quite a bit. On the other hand, we do hear from primary care physicians that once they've used a digital tool, they don't want to go back because it does allow them to task shift to a lower cost resource. It does allow them to smooth things out in their workflow. For those of you that are interested, there are some policy changes that probably need to be made in order to make some of these things easier, specifically around reimbursement. The Alzheimer's Policy Working Group is an organization that you can follow that's working on that. And if you'd like to add your voice to that, we know that it's powerful. So I'm going to keep moving because we do have a chock full agenda today. So, Stephen, you're right. First, we have to detect cognitive impairment. We've got to do that first step of early detection. And once we do that, we know that we can help a family, whether that be the newest therapies or care and support, individuals getting to have their own voice in their care, but also things like brain healthy behaviors. We hear lots of conversations about mild cognitive impairment that can either be reversed or stabilized when we find out that someone's sleep apnea, for example, is uncontrolled or their diabetes is a problem. And when they sort some of those things out, medication issues, all of a sudden some of that cognitive impairment is maybe not progressing the way we might have expected. But sometimes it will still progress. And we find that that cognitive impairment could actually be a sign of something greater. That's where we need to get to accurate diagnosis, and specifically the advent of the new blood-based biomarkers, which allow us to move away simply from PET or lumbar puncture. And it allows us to maybe even in primary care, start to get a handle on what the pathology could be that's causing the cognitive impairment. Two recent guidance came out, one from the Alzheimer's Association and one from the CEO Initiative Against Alzheimer's. They are a little bit different. Primarily, they're different in who should be using the tests. So the Alzheimer's Association focuses largely on specialty care, where the CEOi guidance says that there's a role for primary care here as well in blood-based biomarkers. So do you want to talk a little bit about the accurate diagnosis step in this journey, Stephen?
Sure. We'll start with the specialist. I think they won't be as germane to the audience, but just I think to be aware that the specificity changes a little bit just because the population that a specialist will see is going to be different. That pretest probability is going to be lower in a PCP population than in a specialist environment. And so what we see happening here with specialists is they're using the biomarkers as a substitute for an amyloid PET or a lumbar puncture. So this is really exciting. Neither of those are neither the CSF analysis or the PET scan are cheap or enjoyable to get for patients. And so being able to have a blood test is going to be a superior experience, I think, for patients and families. But the specialists are using them, that ability to skip a PET scan, for instance, is not applicable yet in the primary care environment. So in primary care, the way that I think about this is that the blood markers are helpful for ruling out Alzheimer's, not necessarily for ruling in. And that goes back to the specificity and sensitivity and this pretest probability. So, in the primary care environment, I would say that if you have a positive uh, BBM, then you still need some type of confirmatory testing, or they need to see a specialist, either one. I think it's important to note that for the most part, with the beta amyloid and the p-tau, these are covered by traditional Medicare. But if you have a Medicare Advantage plan, what we've seen is that those are not covered uniformly. They generally are, but not uniformly. And so, what you don't want is a patient to get an unexpected bill for several $100s. And so that's something I think to think about as well for the patient and family experience. The other thing to note is, if somebody is asymptomatic, these tests in primary care are probably not appropriate. We can talk more about that toward the end if there are questions about that, but I think that's a good thing to know that right now there's not enough data for, a healthy 50-year-old, for instance, who comes in and says, "Hey, I have Alzheimer's in the family. Do these blood tests on me." And it's very likely that those tests wouldn't be paid for. But the data on these blood tests are evolving rapidly. I think that if we wait 6 months and have another one of these webinars, that there'll be some changes in the guidance here. And so it's really good to know about. I think that they're useful. I practice in Central Texas in the Austin area. My wait time for me when I send a patient to neurology right now is 6 to 8 months. This may help me, getting these may give me a little bit of a jump start on what I think is happening with the patient. And so, if you're also in a place where getting to a neurologist is difficult, then think the blood biomarkers because it may give you sort of a weather vane on what's happening with the patient.
No, that's great. Thank you very much, Stephen. And for the folks that are less familiar with the regulatory situation about blood biomarkers, of course, a test can be used if it's a lab developed test and the lab is CLIA certified. But the gold standard, of course, is FDA approval. And there are two tests that are approved right now. As Stephen mentioned, the p-tau 181 test is approved for use in primary care as a rule out test. And then the p-tau 217 test is approved for use to rule in. And the good news is that Medicare has added the blood test as one of the drop-down options for the registry for the new anti-amyloid therapies. Now, whether the payer that you work with will allow that to be used as a single proof of pathology, that varies from state to state, but as it relates to Medicare fee for service, it is able to be used. So I think that's very good news because as we move on to the next question, which is what's going on with these anti-amyloid therapies, one thing we do know very clearly is they work better if they're used earlier. And as Stephen mentioned, right now there is a very, very long wait for neurology across the country. And largely that's because we have people that are in those queues that have not been triaged by using, for example, a blood biomarker test or one of the other pathology tests. So by ordering that test, you may actually be able to fast track some of your patients into neurology if in fact they are a candidate or are interested in learning more about one of these new therapies. So, Stephen, the data that's in front of us right now is for one of those new therapies. There's two that have been approved, lecanemab or Leqembi and donanemab or Kisunla. They're fairly similar. Obviously, Kisunla is used once a month by infusion. Leqembi was originally approved to be used twice a month by infusion, but there's some new data that has come out in lecanemab just recently, and that's what's in front of us. Do you want to talk a little bit about some of the new data on Leqembi for 2026?
Sure. Yeah. So I think it's most of us in the clinical realm call these MABs. They're monoclonal antibodies, and it's much easier to refer them as MABs than to say the entire name. Like Phil said, there's two of them. Um, Lecanemab has now two different forms, so they both came out with as infusions without a real stop date. So these are aimed at people with MCI or mild dementia. If they have more advanced dementia, then they're not even candidates. And so it gets back to the first point around assessment and making sure that people have the diagnosis. So there are a number of things like the guide program from CMS that we can talk about, or these infusions of monoclonal antibodies that require a diagnosis before there's any kind of consideration. And so um, uh, there's not a well-defined endpoint for either of these treatments. Think somewhere around at least 18 months, but may extend beyond that, 2 or even 2.5 years. And the benefit to the patient is that it significantly slows down the progression of dementia. So doesn't make it go away. But so I'm in this work because I was raised by my grandfather and he had dementia. And if I had more meaningful moments with him, I'd get him on these drugs as quickly as I could. But having said that, getting people on these drugs is not easy. The timing has to be right. They have to have the diagnosis. You have to have the resources in the community. You have to be able to send a patient to neurology. I think, interestingly, because the uptake of these drugs isn't what a lot of people hoped it would be, sometimes neurologists will, if you've done all that you need to do to sort of tee things up for the neurologist, they may actually be able to get them in faster if they know it's for this therapy than they would if it's just starting an evaluation. Um, the way I would frame this with your patients is that there are medications now that can be given through an IV, although lecanemab now has a sub-Q version as well that can be done at home. But we have these medications. You have to medically qualify for them to make sure that you don't have anything that would cause you harm or bad side effects in your medical history that these drugs may bring out or elicit. The biggest of which is what's called ARIA, amyloid-related imaging abnormalities. You can see either on imaging edema or hemorrhages. And so people, for instance, on anticoagulation are not candidates for these medications, but you can tell them that the neurologist can evaluate them and hopefully, if they're able to get on them, slow down the progression of the illness. But again, want to emphasize with these drugs, they are currently underutilized because we are not doing the assessment and making a diagnosis in time.
Thank you, Stephen. Keep those questions coming in. We've got a few coming in. We're going to run short on time, which we always do when we have these great topics. But we did get asked the question of will these slides be made available? Both the recording and the slides will be made available, as well as the links to the external research that's been presented on each of these topics. So you mentioned this already, Stephen. I'm not going to spend a lot of time here, but what we know is that timing is everything. We know that if we can identify patients early that have unrecognized cognitive impairment, all sorts of good things can happen for that family. You've mentioned things like care and support for the family, the guide program, dementia care. I'm a real advocate for people having a voice in their own care, and catching that early is important, but so is brain health education, things that you might be able to do, either at lifestyle change or medication change, managing comorbid conditions that can help stabilize cognition or even improve it. Also, a reminder that geriatric depression looks a lot like cognitive impairment. And so there's things we can do there. There's also the ability to put people on new therapies or to consider a clinical trial. So lots of opportunities. Can you just hit the highlights really quick about the difference between a non-structured program, maybe where we wait until someone comes in or there's a crisis, right? We know that 25% of dementia diagnoses are made in an ER, which is exactly the place you don't want them made, versus what happens when you have a structured screening program.
Yeah. I mean, my family fell into this without things being really structured and thoughtful. It is chaos, confusion, and catastrophe. The three C's, honestly. That's what it's like for patients and families, and we should not be making this diagnosis in the ER or the hospital because somebody now has delirium. And while we can't make the disease go away, we can make this a very different experience for the patient and family when we do assessments early and get them into a treatment plan. And so we're very proactive when we do that. People know what to expect. And so intellectually and emotionally, everybody trying to support that patient do a whole lot better. And we have better outcomes. We have higher quality of life, and we utilize the healthcare system less. So we have less care that's unwanted, unnecessary, or non-beneficial when we structure things.
Yeah, I'm so sorry for your experience, Stephen. We had a similar one in my family and with so many of my friends, and it's a health system problem. We don't go into the doctor without someone throwing a blood pressure cuff on us, and yet we don't actually do an annual assessment of our brain health. And we know too that we decrease stigma when that happens. If everyone just gets the cognitive assessment that they're legislatively have a right to at the annual wellness visit, that stigma comes down quite a bit. People might seek help more quickly, and your best measure is against yourself. So, just to conclude, for the first time, we actually have a complete diagnostic treatment pathway. Not all of us have the benefit of Dr. Bekanich being our family's doctor. So, you may have to go in and advocate for this if you're a patient, or if you're a physician that wants to make this happen, you may have to advocate for this in your health system. The Davos Alzheimer's Collaborative, which you can find at www.davosalzheimerscollaborative.org, is an open source consortium with tools to help you think through how do you create this brain health pathway. From a digital cognitive assessment that allows you early detection, to blood-based biomarkers that allow you accurate diagnosis, and then a treatment pathway that makes sense for that patient, whether that's care and support, whether that's referral to a guide program, brain health education, a clinical trial, or one of the new anti-amyloid therapies, which we know work better the earlier that they're used. There's not a disease that I can think of where the outcomes are better if we wait longer to diagnose. So let's catch this disease early. Stephen, any closing comments from you as we get to the very end of our time here?
No, just outside of, I know we didn't get to questions. I'm sorry about that. Please get in touch with us. I will personally answer any questions that come my way, and really appreciate you all being thoughtful about this and giving and sharing your time with us.
So, Stephen, I'm going to cue you for one final comment here. Why are you hopeful? It's been a long time for us to see the kind of innovation that we've had scientifically in Alzheimer's disease and having a different conversation. Why are you hopeful?
Yeah, I think two things. One, So it's going to be some time before all the different forms of dementia are cured. I probably am not going to live to see that. But there's two things. One is that I think that we're being much more thoughtful around proactive brain health and not getting to a place where we have so many people with dementia. And I think that's amazing. There's lots of science on that. There's great interest. And then on the for those that are diagnosed, I'm hopeful that people have a better experience. We cannot remove all the suffering that goes along with this devastating diagnosis, but we can certainly make the journey much easier than it has been traditionally, and that's something worth fighting for.
I couldn't agree more. Let's go make that change. And big
Yeah.
thank you, Mary, to you and BrainCheck for hosting this webinar.
Yeah, I like Stephen, Phyllis could not have said any of that better myself. So I hate to not end it exactly right there, but I do want to thank everybody for attending today. Thank you, Phyllis, Stephen, for sharing your time and expertise with us. And if you are interested in more resources, some of our blogs, scientific publications that cover some of this content matter, more related to BrainCheck specifically, and future webinars, please check out braincheck.com. And I'll leave you with that. Thank you to everyone for attending. We'll see you next time. We have many more of these to come. Thank you.
Thank you.
Bye.